Okay, ladies and gentlemen, we're going to go ahead and resume our agenda as planned. We want to make sure everybody gets back to their offices or back home as scheduled today. So at this point, we want to welcome Mr. Mike Maples. He is the Assistant Commissioner of Mental Health and Substance Abuse Services for the Department of State Health Services. Please, everyone, welcome Mr. Maples with a warm round of applause.
Thank you, and I'm glad I've got the prize spot of speaking after lunch. And certainly after the speakers that spoke at lunch, there's quite a bar for me to reach for, and very interesting and stimulating discussions. But I'm going to try to talk about, I wanted to first extend our Commissioner for the Department of State Health Services, Dr. David Lakey, was unavailable to come today. He sent me and said please extend his good wishes and wishes for a successful meeting. We did talk about some of the things that I'm going to go over today. I'm going to try to cover a gauntlet of a lot of information that I hope will add to the conversation. I also wanted to give you a little background about the agency. I am a state employee. I work for the state of Texas. So I always joke about, we've got the advocacy and provider side, and we've got our legislators, and then you have the state agencies in the middle who reach out across both ways and say, how do we come together to make services work? And one of the challenges that happened prior to 2004, I got this up here, in 2004, the state agencies in the state of Texas had a dramatic change. The health department, the substance abuse state agency, and the mental health state agency, which were all previously separated, came together September 4th, 2004. And I mean it, that day, we came together as one state agency, which there was a lot of concern at the time about what that would mean to mental health and substance abuse service delivery into the future. The health department was quite a bit larger. Mental health was the middle, and then the substance abuse agency was the smaller of the agencies. And it was an interesting time to bring everybody together to focus on and get focus on the mental health and substance abuse issues in the state of Texas. Previous to this, the mental health and substance abuse agencies had worked very well together in focusing on dual disorder treatment or supporting treatment across the state. I actually had an employee that worked for me at the time, because I came from the mental health agency, that was part-time employed by myself and part-time employed by the substance abuse agency. And we went through several of those positions before somebody finally came along and said, working for two state agencies is a difficult proposition, especially when it comes to mental health and substance abuse issues. But we stayed committed to that, saying we're going to work through these topics, and the intent is not for one to take over the other or to work sequentially or to work separately, but to integrate the care that we do, integrate the functions that we do. So we took that same approach as we moved into 2004, where we were going to come together as an agency and also bring in our health partners, and starting to take the focus of, in a real way, of people, and not disorders, and not looking at them separately. But we have now responsibility for the whole person. We had an initial mission statement that was sound mind, sound body. It's evolved into just a healthy Texas, which is our approach, because we are now all one agency. First days were a little bit rough as we start bringing things together. When I started bringing my first staff meeting, where I bring in folks to the table, the mental health and substance abuse folks to the table, I thought there for the first few days I was going to put tape down the hallway and say the two we're mental health and we're substance abuse. But over time, again, having us as that agency together has put that focus back on the person, which I want to talk about. We were legislatively mandated to come to the table. It was a little bit of a reunification, because the mental health agency at one time had substance abuse, but it had separated before, and so we were coming back together. The research out there in the literature talks about integrated health care in a whole lot different way today than it did in years past, and having to focus on the whole person. So the opportunity was there to do that, certainly. Also bringing in the wellness part, that you can't talk about mental health, or you can't talk about substance abuse a lot of times without talking about mental health. And you can't talk about substance abuse and mental health without talking about health and how it's the whole person is affected, and what we've learned in the way that we're operationalizing the services that we provide here in Texas. As you see, the agencies that came together, we created 4 divisions. I'm actually the second assistant commissioner, the first assistant commissioner who helped organize all of this, and our first commissioner has since retired, and we now have our second commissioner, and I'm the second assistant commissioner over the mental health and substance abuse section, our division. And you can see we have 3 other divisions of prevention and preparedness, family and community health, regulatory, and regional and local health. And these are my counterparts that I work with on a day-to-day basis to keep mental health and substance abuse in the forefront of all health care, and likewise that they have begun to want to keep health care in the forefront of my attention as we start moving our policies and our issues. We now have folks in WIC clinics. We now partner in a lot of places around the state with federally qualified health centers. We now provide a lot of information statewide through our PRC, our resource centers on healthcare issues. A lot of our prevention activity that we focus on healthy lifestyles. Are bringing together these groups and working with our regional health clinics too, that when people come in to get their health care addressed, that we also assess and try to intervene on any mental health or substance abuse issues, learning a lot from an expert project, which is screening, brief intervention, referral, and treatment, where we identified a huge opportunity when you have people in the healthcare setting to screen and intervene for folks that present with substance abuse and at times mental health issues. So a great opportunity as you see the organizational counterparts that we have here at the health department. And just trying to make the case, not only with the health, as I said, I always felt like we have the health department, which I don't know in a lot of states, but is big, and then we're coming to the table. But having to make the case that this is a big issue of mental health and healthcare integration. We reviewed studies and found that 35% of the individuals with SMI had at least one undiagnosed medical disorder. Folks with SMI have higher rates of chronic medical conditions, including hypertension, HIV, AIDS, diabetes, more multiple and medical conditions, higher premature mortality. Several studies on that about persons with mental illness, and I'm going to talk about mental illness, but again, you can't talk about mental illness for very long before you start talking about co-occurring disorders, and that lifespan is 25 years shorter for folks that have a severe mental illness, and certainly more so for those folks that have a dual diagnosis and compounding health care issues related to those issues. Underserved populations many times show up in our public centers, such as the ERs, or in looking for treatment, jails, what have you, in settings that are less than optimal. Our ERs become our primary care settings, where we're trying to do a lot of work of screening and intervening at that point, but really optimally should be getting diverted in our system and our community, be aware of substance abuse treatment providers and mental health treatment provider options in the community that are other options other than our emergency rooms that are already overflowing with way too many incidences of substance abuse related issues and mental health related issues. Individuals with mental illness make up 44% of the U.S. tobacco market. The breast cancer rate for women with serious mental illness is 9.5 times greater. Don't ask me why, but these are issues that we are confronted with in our health care delivery system. Rates of Hep B are 5 times the national prevalence rates, and rates for Hep C are 11 times the national average for folks with mental health and substance abuse disorders. Substance abuse among those with SMI is 29% higher, and 47% of those with schizophrenia and 61% of those with bipolar also have a substance abuse disorder, and I submit that's low, that's diagnosed. And I submit that from our experience that it's oftentimes much higher than that, than what's identified and diagnosed. Our experience has begun now that we've put more tools into primary care setting that it's being assessed and it's being looked at differently. Many times primary care providers or emergency room doctors don't address this issue. They don't care to for fear of not getting paid or what have you, just not wanting to address the issue because of a lack of comfort. So many times this issue goes undiagnosed. Again, when we brought the systems together, I had a provider system of mental health providers and substance abuse providers, and many times, the two provider systems wouldn't want to deal with the other issues. So the other diagnoses weren't often addressed. We assessed you for substance abuse. Sometimes we assessed you for mental illness issues. On the mental health side, we focused on your mental health issues and sometimes addressed and diagnosing your substance abuse issues. And great strides have been made in the whole area of co-occurring disorders for the identification and treatment of those disorders in a coordinated fashion or even integrated fashion. So, and we continue to see those better numbers related to the identification of substance abuse issues in our mental health population. Oops, going backwards. As I said, individuals with schizophrenia have a 20% shorter lifespan, and new information, more information coming out about a landmark study showing that, in fact, it's 25 years shorter for having a severe mental illness. People with SMI are often linked to obesity, higher smoking rate, higher use of alcohol and tobacco, other drugs. Some drugs used to treat schizophrenia are linked to weight gain and onset diabetes. And experts recommend MH providers perform physical health monitoring, typically occurs in the primary care setting. We've also gone through this issue with tobacco and addressing it as a significant issue that needs to be addressed, eliminating it from our state hospital campuses, providing prevention, education, information for folks both in our mental health and substance abuse systems about the ill effects of smoking, high prevalence rates on both the mental health and substance abuse sides for the use of tobacco. And we have integrated into our programs, into our systems, tobacco cessation, and I'm going to talk about that a little bit more in a minute. The forgotten drug, or the drug that's not talked about enough, is the ill effects of tobacco, especially disproportionately on folks that have mental health and substance abuse disorders. You see mental illness strikes more Americans each year than any other serious mental illness. 56% of state prisoners and 64% of local jail inmates had mental health needs, according to the Department of Justice study in 2006. 74% of state prisoners abused alcohol or drugs. 37% of the state prisoners used drugs at the time of their offense. And 13% of the state prisoners were homeless in the year before their incarceration. As we talked about, I think we mentioned it earlier about the whole criminal justice side of the issues in Texas is, and I've been downtown and talked with legislators, talked about folks about the need for mental health and substance abuse treatment, understanding that it's necessary in the prison system, but also understanding that the investment of dollars and resources and a focus on dollars in the community to prevent substance abuse and mental health disorders of getting to the point that criminal justice involvement ensues. And had a lot of positive discussions, and I'm going to talk a little bit about crisis services and how that's had an effect, but the investment in the community level to help curb some of these statistics that we're starting to look at, that the prison systems fill up with folks that have substance abuse disorders and substance abuse issues that, had they been addressed through prevention or treatment activities in the community, certainly would have freed up the space in the prisons for folks who need to be in prison and not for folks who need substance abuse treatment or mental health treatment. Very significant work in that area that Texas certainly, with the size of Texas and the number of people that we have in the criminal justice system, need to pay attention to. More states, 27% of state prisoners reported physical or sexual abuse. 1 in 3 of the state prisoners had received mental health treatment since admission. That's a really interesting fact. In Texas, I don't know how many of y'all know this, that we have statutes that allow us to match records at booking level of folks with the mental health system and the criminal justice system. So at booking, I can, the mental health providers and for substance abuse providers as well for mental health, not for substance abuse, but can query our system and see, does that person have a history of being treated in the mental health system? and we can provide that information back, even though HIPAA is enacted. State law in Texas allows it to occur, and we do a lot of that pre-identification of folks that have been in the system before at the booking level, and be able to provide diversion opportunities before they ever get into the criminal justice system, and made excellent strides to keep those number of people that we already know may have a history of mental illness from penetrating further into the criminal justice system. And again, a good majority of those have substance abuse issues as well. Even though we don't match, or we don't look at the substance abuse data as far as matching in Texas without consent like we can with the mental health system, we do identify those folks early on and divert them out of the system and identify their needs. Texas is almost 50% more of its population under correctional supervision than the national average. And again, as we saw in the previous statistics, many of those are related to substance abuse issues. One of the other pieces of information I put in here, even though it's a little dated, but the trend has been going this way, is that our capacity in the state of Texas to provide adequate alternatives for mental health and their co-occurring disorders is diminished pretty dramatically. And this has changed even farther, though I haven't updated this slide, that the state hospital system has grown even larger, and the private hospital system as alternatives to folks with mental health and substance abuse disorders has diminished. You can see the number of beds, though, in Texas for state hospitals as an alternative has declined, slightly increased in 2006, but has declined overall, with forensic commitments growing. And again, these forensic commitments are people that are not competent to stand trial or not guilty by reason of insanity, significant substance abuse issues related to them getting into the criminal justice system, high dual diagnosis combination or substance abuse issues related to these folks who are eventually found incompetent to stand trial. That this becomes a significant focus, even to the fact that we not only have implemented in the community system significant dual diagnosis services and competency expectations of providers, but have the exact same competency expectations in our state hospital staff. Oops, wrong way again. They're talking specifically about substance abuse and the economic impact. I think we were talking about this before, is, we can't afford not to do significant prevention and treatment or alternatives in the community. In Texas alone, the economic impact is $33 billion estimated in 2007 of the economic impact of substance abuse. And you can see some of the statistics in Texas leads or is higher incidence of alcohol-related fatalities related to vehicle accidents than the nation. And having to, where do we address intervening in the substance abuse issues at a point that we can curb the DWI or the driving while intoxicated laws, and the different laws that we continue to look at about how to curb that, and again, interventions and opportunities to divert folks from the criminal justice system and get them into treatment, where we can start bringing these numbers down more. Here's the part that I'm probably the least proud of, is what kind of impact we, as the Department of State Health Services, though this isn't all of the funds that go into substance abuse treatment in Texas, but when I look across with what I provide in the state of Texas, looking at an overall population of people that are 12 years of age or older of 19 million, the estimated number that have a substance abuse chemical dependency disorder being 18 million, and the number served by my substance abuse treatment programs being only 3.5% of the population in need. And if I adjust for poverty, it only goes up to 7.5% of those that are in need and have no other resources. This is the grim reality of the state of issues in the state of Texas about the need is much greater than the resources that we have available to treat this population. And then, again, if we look at this, the co-occurring overlap between the two systems, 24%, and I submit that's an underreported number, and but still pretty startling about how many of the folks that are served in our mental health system that have a co-occurring disorder, and that we're addressing about 24% of that population. General revenue funding, that's state funding toward mental health and toward substance abuse services, been pretty steady over the last few years. The balance of the dollars, we have about $164 million total in substance abuse resources that we put out for prevention, intervention, and treatment in the state of Texas. This is the state allocated amount of state funds. In contrast, I have about $300 million in mental health dollars attributed to mental health care in the state of Texas. We'll talk a little bit about the good news, but I want to applaud anybody that's been involved with mental health or substance abuse treatment provision or advocacy or what have you. Is in the last legislative session, the DSHS, Department of State Health Services, was awarded $82 million to revamp its front door crisis system, which was a significant event for Texas in solving a problem. And that we had done some work pre the legislative session about what were the major issues. ERs, law enforcement, family members, advocacy organizations all said for people with mental health and substance abuse, you know, they really don't have any alternatives when they have a problem or they go into crisis. They end up in jail, ER, homeless, what have you. So we made a significant pitch to go in working with our communities through in developing, and it's on our website, a task force of providers, advocates, law enforcement representatives, ER physicians, and what have you, to come up with some recommendations and ask for some money. And you can see that report online. And we asked for $82 million all throughout the session. It went up and down. It disappeared. It wasn't heard about. Then all of a sudden, at the end of the day, we had a rally, and they funded exactly what we asked for, $27 million in the first year, the balance of which came in the second year. And we had some goals associated with that: establish better local systems to serve persons in crisis. Again, we're not talking, at the time of crisis, mental health, substance abuse, any of that doesn't matter. We respond to crisis. Now, many times, once the crisis is resolved, we find out you've got it's a substance abuse issue or a mental health issue, or it's both, or what have you. We're all one system now, so we get you into where you need to be. But our crisis system is robust now that we go out and we deal with folks regardless of whether it's a mental health or substance abuse or person just having a hard time. Our goals were to reduce utilization of the ERs, the state hospitals, or other inpatient beds, or to reduce the overtaxing of law enforcement resources that are out having to deal with this, and improve customers' access to the appropriate setting. Let's get them into the setting where they need to be in order to recover, in order to get their lives back on track. This money was put to augment the already basic services. We also have an evaluation associated with this that we're in the middle of. Preliminary results have said things are better. Law enforcement, ER doctors, family members, advocates are all much happier than they were before. Have we solved the problem? No. But we have certainly got processes in place so that anybody in Texas that has a problem has a place to call, has a place to go to deal with that. The first things we did is created a hotline certified by the American Association of Suicidology, and also developed mobile outreach teams that hotline could dispatch. And they're trained in mental health and substance abuse assessment, child assessment, and intervention, adult assessment. And we would rather this be the front line than the law enforcement officers. Many, many times across Texas, our mobile outreach teams work, and great examples here in Houston, Texas, where with a lot of the model for how we did this hotline and this mobile outreach was started years ago by local community investment. And they're certainly in the forefront of that and helped us design that. But Harris County has a significant crisis system that we use to model for the rest of the state. Other services that we tried to create, some extended observation units where people could go if they were having a substance abuse crisis or mental health crisis, and we observe them. We have a place for them to go, law enforcement to drop off, and you have appropriate mental health or substance abuse providers there to assess and observe and stabilize and figure out what the next step is. Previously, if all we had was a hospital, that's all we got. Everybody went to the hospital or they went back to jail. Now we're trying to create some more options for people with mental health and substance abuse needs, that we can create alternatives, either crisis stabilization units, respite programs. Another significant lesson learned from Harris County was the CIT program, which is the crisis intervention teams that partner mental health providers and specially trained law enforcement officers, which is another significant event to assess for people in mental health or substance abuse crisis. Also invested $25 million into an RFP proposal that put dollars out there to develop a bunch in parts of the state where in our rural communities they had nothing. They have the local small community hospital, and they're the ones that are creating these crisis respite or residential programs or observation units where people can be taken that are having a significant mental health or substance abuse crisis. You can see the uptick in the numbers. We're certainly on an average month serving a whole lot more than we were before. The number of people in our outpatient programs is up, and the residential programs are slightly down. Some of that has to do with the lateness of the funding getting out. We had to procure those through an RFP, but also on the other side of that means our mobile outreach teams and our community providers are effective at keeping people out of more in residential. They'll be able to solve the problems at people's homes or in the community. And certainly the effect of hospitalization post a crisis intervention on our part or on our provider's part, whether it's mental health or substance abuse, has shown an effect of them keeping them out of the hospital over time. Many of our initiatives, and need to wrap up, I'm getting the signs, so I want to make sure that I get to the key points that I really want to make. Numerous initiatives that we have going on that are all targeting this integrated approach. Mental health transformation. Texas is a mental health transformation state with 16 agencies that come together that provide services to folks with mental health and substance abuse and are working on a strategic plan and developing local community collaboratives that address many of the issues and many of the barriers and many of the silos that were identified as part of mental health transformation. We have an adolescent mental health screening project that, again, focusing on assessment of adolescents in the primary care setting. A pediatric mental health project that put a mental health substance abuse provider in the pediatric clinic to provide services in the pediatrician's office so that they can intervene early and work with other providers. Access to recovery. Great study that we came out of that about recovery supports and what role they play in persons' recovery from substance abuse. I'm going to show you in a minute. It's a part of our legislative ask going into this next legislative session is to incorporate recovery supports beyond just the ATR program, but into business as usual. The Texas Recovery Initiative is another project where we brought substance abuse stakeholders to the table and said, if we were to revamp the system, what do we need? And essentially got those ingredients from the substance abuse community, which led to our legislative ask that we're going to make that says these are the things that the community and advocates have come together to say we need to fund the system. Columbus is our integrated health care record. Many of you may know that are in the substance abuse provider system in our world as BHIPs. Columbus this is BHIPs on steroids. It's integrated mental health, substance abuse, electronic health record that deals with all of that, deals with the billing, deals with the cross-coordination with other providers. If you're in the mental health system and the substance abuse system, you can both access your record, you can give consent and they can see it all, and you've got your providers all working together off one single electronic health record. Integrated disaster response, I probably can't not come to Houston and talk about Ike, Gustav, Edward, or Dolly, and be able to talk about the significant events that have happened in the last several months in our disaster response, mental health and substance abuse wise. We've learned a lot of lessons from Katrina about busloads of folks showing up in our state and not having access to methadone and not thinking through those issues. Didn't happen during these last issues. Methadone clinics were set up just as quickly as the healthcare clinics were set up, and the methadone providers stepped up to the plate, as well as the substance abuse providers stepped up to the plate to help do crisis counseling and case management with their mental health counterparts. And we do have now an integrated behavioral health response to crises that we'll continue. I just had an email exchange while sitting over here about some follow-up, what we call after-action reports on behavioral health response from Ike that we'll be working on to improve even more on our mental health and substance abuse response to that. And tobacco having a significant comprehensive program for tobacco cessation. I do want to get to really quickly what we're going to ask for in this next legislative session. It's about an $80 million ask for substance abuse services that we're going to ask for is into the mental health system, similar to what we did on the mental health side. We're going to ask for on the substance abuse side a significant amount of money to infuse into the system. The first largest amount of the money is going to be for a treatment rate increase so that our providers, we can retain our providers. We're losing providers all the time because of unable to continue to provide the services for what the rate is, with a larger increase for detox providers since they are severely underpaid, and being able to provide additional resources on top of just across the board increase additional resources for detox providers. That will be able to keep those providers in the system and attract more. Increased prevention services. I think everybody knows about prevention. A dollar invested saves $5 later. Significant effort on the state of Texas in our prevention program. Certainly wanting to expand that as we ask for more money. Expanding residential detox, asking for additional detox beds. Oops. I think it's, we have 6 beds in Harris County to deal with detox. We have a significant issue with needing more detox beds in the state and going to be asking for additional money for that. Also, Medicaid. The state of Texas doesn't have an adult Medicaid benefit for substance abuse, and we're going to ask this year for the third time to do a Medicaid benefit for adults, and this is focusing on outpatient detoxification and treatment, which has got a lot of attention this year that we feel will be significant to get our foot in the door. We've also had folks approach us about expanding that to other types of service, but right now if we can get a substance abuse benefit for adults, we feel like we'd have quite a victory. As I talked about before, lessons learned from our ATR program is getting recovery supports as an adjunct. If you can't have child care, you can't have sober living, you can't have the supports that you need to support you in recovery, your completion rates and your absence rates are much lower. We learned from our ATR project. Expanding our OSAR function, which is our outreach and screening and referral system, essentially the front door to the system, needing to expand that. Expand detox or options for folks with co-occurring disorders. We found that out too in our crisis redesign. We have a lot of folks that need a detox that are in the mental health system, and being able to specifically purchase and set up co-occurring detox beds will be very important. Also, medication-assisted treatment, moving on beyond just methadone, but we've learned a lot about Suboxone and buprenorphine and other medications that are very helpful for people to recover and have good outcomes, and we're going to look to expand that somewhat during this next legislative session. And just for our mental health exceptional item, it's a little bit different, but focusing on continuing to expand our crisis system for mental health and substance abuse, looking at transitional mental health services and services for folks with having a substance abuse crisis, and be able to transition those. We have a lot of folks that go through the crisis system that then choose not to go into, for whatever reason, into ongoing care, and looking to wrap services and supports around them through peer support models for persons already in recovery to help engage them into treatment. And then ongoing services to make sure that we have capacity. What we found out too with the crisis expansion was we did a whole lot more crisis services, $82 million in the crisis system. But if you didn't expand the ongoing mental health basic services, these folks had nowhere to go that we just stabilized. So looking to create more capacity in our general mental health system. That was the 100-mile dash down the Department of State Health Services. And understanding there's a whole lot more. This is the state's piece of the pie. And I think you've heard from a lot of folks, but the state authority for mental health and substance abuse is right there with you. Our new commissioner is very interested in it. Even though his background is infectious disease, he's got a big focus on understanding and being active in the mental health and substance abuse treatment area. And appreciate y'all's attention today. Thank you.
Thank you, Mr. Maples, for your insight on substance abuse in relation to mental health services. We know there are a lot of people in need out there, that's for sure, so thank you. Okay, we want to keep our program moving. However, I do realize some of you might have to slip out as the afternoon progresses. If you do, in regards to parking, please see the registration desk for your validation ticket so we can help you out with that. Back to our schedule here, I want to introduce to you Dr. Robert Landry. He's our Drug Summit facilitator, and I think he deserves a rather large round of applause. A very well orchestrated program I think plenty of you are finding beneficial this afternoon. I know I am.
Okay, we need to move forward from the effort we started this morning. A couple of things. One, we would like to work in groups that are about table size. So if there's just 2 or 3 of you at a table, you might want to move, or we'd encourage you to move to a table that has some openings. Also, we need a facilitator with each of the groups. So if you're sitting at a table with no facilitator, if you'd merge with one of the group or one of the groups that has a facilitator at the table, it would really enhance what we can do. Okay, we're going to break this afternoon up into 2 sessions. One, we're going to finish what we started this morning, and then we'll take like a 10-minute break, and then we'll finish the second part or this afternoon's piece. So what we want to do right now is to begin to collect the information that we got from one another this morning, some of the input that people gave you this morning. So in each group, what we hope to do is brainstorm those challenges, those problems you identified in the community. We want to come up with a list that's generated by everyone in the group. Okay? Second, once we do that, we want to prioritize that list down to the top 3. So we ask you to, around the table, prioritize the list that you come up with to what are the top 3 concerns in the area. And prioritize them 1, 2, and 3. Okay? The second thing is we need to have a scribe at each of the tables. So one of the things the facilitator is going to ask you to do is for someone to volunteer to be the scribe and write the information down. We have a set of forms that we want to transfer the information to and to complete the process. The second part of the afternoon, after we take a break, we're going to go through the rationale and justification associated with those priorities. Why are those priorities, and why are those priorities here? You know, I'll share a story with you that kind of brings the point forward. My grandson just went to kindergarten this year. And he came home on the first day of school and he told his mother that he was worried about the teacher, that his teacher wasn't very smart. And she said, well, what do you mean? He said, she put name tags on all of us and we don't even read. So sometimes we need to understand the purpose of what we plan and why we plan it. So that second part of the afternoon, we're going to take a look at the rationale and justification behind those priority points that you select. So right now, I'm going to turn it over to the table facilitators. We will come back together, or I'll come back up about 5 minutes till. And what we would like to do at that time is have some of you volunteer to share the priorities that you came up with. Then we'll take a 10-minute break, and then we'll do the piece on the rationale and justification. So if you would, I'm going to turn it over to the facilitators now. If you have any questions, I'll be around. I'd be glad to step over and help you.